Evening, friends. Sorry for the delay of couple of minutes. I'm just setting up the other connections. Can I request all of you to mute, please? So, welcome to this evening PG clinics. We have the invited faculty, Professor Madhuri ma'am, Professor Sridhar sir. We have others joining shortly. We have Srinivasan sir and other senior faculty who have joined today. Warm welcome to all of you. And this today's candidates are kindly contributed by Professor Srinivasan sir from Coimbatore Medical College and Professor Sridhar sir from Apollo Medical College, Hyderabad. So we have two cases for the day. We have one case of parotid tumor and one case of oral cancer. So the faculty will allowing the candidate to run through the history part of it. At the end of history, the candidate will sum up the history and the faculty can go back to the slides one after the other from the beginning and ask questions. So same way during the clinical finding part, candidate will be allowed to present till the end without halting. And after the arriving at the diagnosis, they can go back to the general examination slide and they can take one after the other questions. So I request the faculty, if the candidate finds difficult to answer, please give the right answer from what you will be expecting as an examiner so that this will be a learning session. We have 1 hour for each case discussion, which is designed longer. The first half an hour goes for the clinical management part of it, clinical history, making a diagnosis. The second can be taken up for evaluation, which will be a basic as well as the specific evaluation and how to interpret the evaluation. Then a little bit about the surgical management and then complications as well. So we'll finish the first case in 1 hour's time and then we'll take up the candidate, second candidate later. So we wish both the candidates good luck and thank all the examiners for kindly sharing their valuable time to join us this evening. We also warmly welcome Professor Anandi. Anandi is a professor of surgery at Government Stanley Medical College. Madhuri ma'am is from LTM Medical College, Mumbai. Sridhar sir is professor and head of the department at Apollo Medical College, Hyderabad. Thank you, friends, and good luck to you. Can I request Dr. Sharat Chapidi from Apollo Medical College to share the PPT and start his presentation? Faculty, kindly take over, and good luck to both the children. Good luck to you.
Anandi madam, good evening. Anandi madam, good evening. Madhuri madam, good evening.
She's
Good
just
evening.
joining. Good evening, madam.
Evening.
Welcome. Sharat, you can introduce yourself, your unit chief, your head of the department, and start your presentation. Good luck to you.
Good evening, sir. Srinivasan, sir.
Madam, good evening, madam.
Good evening.
Thank you, sir. I'm
Good evening, ma'am.
Can we start, esteemed faculty? Can we start now?
Yes, sir. Yes, sir. Sir, Sharat, you could start presenting. Madam, madam.
Madhuri ma'am, good evening, ma'am.
Good evening. Can you hear me?
Yes,
Very
madam.
well, ma'am. Very well. We could see you.
Okay.
Thank you, ma'am, for
Thank you,
joining
sir.
in spite of being on a vacation, ma'am. Thank you very much.
But if my connection goes, I might disappear in between, as I told you in the
Ma'am, that is
morning.
perfectly understandable, ma'am. Thank you for joining, ma'am.
And just a correction. I'm no longer, I've retired from LTMGH, but
Okay,
I'm
ma'am.
practicing it. Yeah.
Very good, ma'am. Very good, ma'am. Very good. I will make it
Thank you.
formal. That make things easier. Thank you, ma'am. Good day.
Thank you.
Please start the presentation, Dr. Sarath. Good luck to you.
Thank you, sir.
Chocolate.
Good evening, everyone. I'm Dr. Sarath Chandra Chapidi from Apollo Medical College. My guide is Dr. L. Sridhar sir, our professor and HOD at the Department of General Surgery, and Dr. Fayaz Hussain sir, professor in the Department of General Surgery. Today, I'm going to present a case of buccal mucosa carcinoma. The chief complaints, a 32-year-old gentleman hailing from Amberpet, Hyderabad, who is a receptionist, came to the OPD with chief complaints of ulcer in the right gingivobuccal sulcus for 2 months. This is the clinical picture. History of present illness. Patient was apparently asymptomatic 2 months ago. To start with, he noticed an ulcer over the gingivobuccal sulcus on the lower jaw on the right side for 2 months, which was approximately 1 by 1 centimeter when noticed and gradually progressed to the current size with no associated pain. There is history of bleeding while brushing noted for 2 months, history of halitosis present, history of chewing pan masala 15 years ago for 5 years. There is no complaints of trauma, no complaints of excessive salivation, no complaints of difficulty in speech or swallowing, no difficulty in mouth opening or movements of the tongue, no loose teeth, or no complaints of ear pain. There is no complaints of loss of sensation in the lower jaw, no complaints of cough, no complaints of bone pains or seizures. There is no history of loss of weight or appetite. Past history, there are no known comorbidities, no history of low dose irradiation in childhood, no history of cancer related deaths in the family. Patient takes mixed diet, has adequate sleep, bowel and bladder habits are regular, and there are no addictions currently. To summarize after the history, a 32-year-old gentleman came with the complaints of ulcer in the gingivobuccal sulcus over the lower jaw on right side, associated with bleeding, halitosis, and history of chewing pan masala for 15 years ago for 5 years, with no symptoms as to of distant metastasis.
Madam, you can take over.
Slide.
Yeah.
Go to the first slide bar.
Am I audible?
Yes. Can hear you.
Yes, madam, you are audible.
When you're going to present in the complaints, it is better you can say patient has a complaints of an ulcer
Anandi, madam,
the
you are
right-
not
on the inner aspect of the
not
Am I
audible,
not
madam.
audible? Am I
Madam,
audible now, sir?
headset போட்டிருக்கீங்களா madam? Are you wearing headset?
Yes, sir.
இப்ப கேக்குது
Now
madam.
it is better, ma'am. Now much better, ma'am. Yes, ma'am.
Okay, right. Fine.
Yeah.
Regarding
Is every
in the complaints, you should write it as right side cheek on the inner aspect rather than writing on the right gingivobuccal sulcus. That is not in the patient own terminology. That is a medical terminology.
Medical.
That should not be coming in your
And-
complaints, right?
Okay.
This is your first slide.
Yeah.
Yeah. We'll go on to the next slide. Okay, next. So how do you said the patient has what is the reason
Sorry, ma'am.
for
Madam,
the
headset எடுத்துருங்க madam.
halitosis?
Headset
I think madam's connectivity is madam.
Headset.
Madam, otherwise you switch off the video. We'll be able to use the bandwidth for the audio, ma'am.
Babita madam has joined.
Actually, you're having problem with the link. Is everyone having problem with the link?
No madam,
Is
it
okay
is
now?
audible. You are audible.
Anandi, okay, yes.
Yeah. Yeah. But I
Hello.
mean, I'm losing the connection in between, or is everyone losing the connection in between?
Madam, you can switch off the video and you can speak, madam. No problem.
Okay, what is the reason for the
I'll switch off the
halitosis?
video.
Sharat?
Sorry,
Anand,
Ma'am, please proceed, ma'am.
Yes, ma'am.
Sharat,
Anandi,
what is
madam.
the reason for this halitosis?
I think it's just slough present at the over the ulcer, ma'am.
Okay. Why does it produce this halitosis? It tends to produce some compound. What is that compound called as? Which gives us bad breath. Those are called as mercaptans.
Okay.
Okay, that is the reason why you get this halitosis. Because of the stasis and the stuff which is present over there and the bacterial action over it, it tends to produce this butyric compounds. These are called as the mercaptans. Okay. And on the next slide, you have written everything as no complaints. It's coming on to the next slide. Can we move to the next slide? It should not be complaints. It should be all history. Okay.
Yes, ma'am.
You got it?
Yes, ma'am.
And can I make a comment on this? Hello,
Saran,
Yes, ma'am.
am I
am I
audible?
audible to you?
Yes, ma'am.
Madhuri
Karan?
ma'am, you are perfectly audible,
Okay.
Madhuri ma'am.
Fine.
Anandi ma'am,
Okay.
you are also audible.
Yes, ma'am.
Madhuri ma'am
Go
wanted
ahead.
to ask one question, ma'am. Let
Can
ma'am
I-
finish.
Yeah, I just wanted to make a comment on this slide, particular one.
Yes,
I
ma'am.
think during presentation, you shouldn't be wasting too much time on saying this separately, everything. No complaints of trauma, no complaints of difficulty, you can combine it and say that there is no history of trauma or there is no complaint of excessive salivation, difficulty in speech, difficulty in swallowing. I mean, instead of increasing your time in this presentation, particularly the negative ones, you should stress upon the positive symptoms, certainly, but negative symptoms you can combine. So give more time to the examiners to ask you questions. That carries better weightage as far as your evaluation is concerned.
Okay. Thank you.
Okay. Why do you get an excess salivation in this patient and you have a lesion which is present over the cheek? Why you want to ask this question to this patient?
In cases of oral carcinoma, there is a high chance of second primary tumors coming out. So if there is any involvement of the tongue, then patient might complain of excessive salivation.
Where is the ulcer?
Ulcer is on the cheek. Okay. That too on the right side.
And
Why should that be?
CH, if it is a CA buccal mucosa, sorry, in the gingiva, you can ask for the involvement of the tongue or CH, will it involve the tongue?
See, when you have a lesion in the tongue, then you can ask about excess salivation, difficulty in speech, okay, and all those things. Those things will happen only when you have a lesion in the tongue or in the floor of the mouth. The patient will be having these difficulties, right? The patient will have a difficulty to swallow. Whereas when the lesion is present in the cheek, if at all there is an excess salivation, how will you explain it?
If it involves the salivary gland, maybe.
1 by 1 centimeter lower down lesion. At least if it's present on the upper gingival sulcus, then you can talk about it, right?
Yes.
Involving your parotid and causing some salivation.
Or
Correct?
floor of the mouth.
Okay, how do you explain? Why you wanted to know about whether this patient has got a loose teeth?
Involvement of mandible can be, if mandible is involved, there is loose teeth or alveolar.
Okay.
Mandible.
Okay, you mean to say there's a bony involvement. Okay, why you want to know about ear pain?
Also, the signifies the involvement of tongue, ma'am, wherein complaints of external pain in the external auditory canal is complaint in patients involving tongue.
What is the pathway? If you have a tongue lesion, when the patient is going to have a referred burnt pain to the ear, what is the pathway of involvement?
It's the postganglionic chorda tympani nerve, which is branch of lingual nerve, which supplies the lateral part of tongue. And the chorda
Okay.
tympani also supplies the external auditory canal, ma'am.
Okay.
So involvement of this has a referred pain over the external auditory canal.
It's just the chorda tympani or some other nerve also which is going to be there? The auriculotemporal nerve.
Auriculotemporal.
Okay. That will give you the pain to the ear.
Yes.
Right. What are the other causes of ear pain? Nothing related with this case. In a person with having an oral cavity malignancy pertaining to the cheek, when it's going to involve some other thing, can there be an ear pain? When there is a temporomandibular joint which is going to be involved, the patient will have a pain in the ear, but that will not be a referred pain. It will be a consistent pain which will be noted there, right?
Yes.
We'll move on to the next slide. Right. You said that, sir, you wanted to know about the loss of sensation of the lower jaw.
Yes, ma'am.
Right? Only for what you wanted to rule out?
It again signifies the involvement of bone, ma'am, wherein the inferior alveolar nerve is enters the mandible through the mental foramen. If it gets infiltrated, there is a loss of sensation.
Okay, on which part of the lower jaw they will have a loss of sensation?
Below the lower lip, ma'am.
Okay, on the midline, almost, right? Just below the lower lip and that part of the jaw, not on the lateral aspects, right?
Yes.
Okay, what are the sites where you have a distant metastasis in oral cavity? You asked about bone pain, seizures, and other things, right? Which is a commonest site for distant metastasis?
Distant metastasis, lungs is the most common site for oral malignancy, ma'am.
Okay.
Followed by bone involvement.
So cough should be the most predominant feature because lung is the most commonest site of your distant metastasis pertaining to oral cavity malignancies. Right. Apart from these things, what other things you need to add in your history? In your presenting illness? What about regional involvement? For that, what is the history you like to ask?
Any other swellings in the neck?
Did you ask about it? It was not written, right?
Yes,
so remember, whenever you're taking a history, remember the TNM, right? For the local area, the nodal area, and for the metastatic area. So when you categorize into these three headings, you'll be not forgetting so that you'll be able to pinpoint all these histories, right? So whenever you're present also, you remember, talk about the tumor first. What are the histories you need to ask? And then you go about to the nodal area, and then you go on to the distant metastatic area. Okay. Ma'am, shall we move on to the next history, ma'am?
Yes, ma'am.
Okay.
Yeah.
We'll go on to the next one, ma'am. Past history. Before that, we talked about this patient had this habit of eating pan masala 15 years back, right? And he has stopped it.
Yes, ma'am.
How long he has stopped it?
For the last 10 years, ma'am.
Even after stopping for the past 10 years, this patient has developed a malignancy.
Yes, ma'am.
Right? So what is the protection which is you get after stopping? Now, okay, what is the risk factor for this patient to develop this malignancy?
This history of chewing pan masala is...
Okay, that was there for almost 15 years back. He has stopped it and 10 years has gone back. Right, now suddenly why it should develop for the past, 2 to 3 months only, you said, no?
Yes, ma'am.
Why it should develop? Nowadays we do see lot of oral cavity malignancies wherein people, they don't eat pan at all. Even then we do see cases, right?
Yes, sir.
In that case, what could be the reason?
Tobacco.
Tobacco. Okay, does he have any habit of eating tobacco
This patient
instead of
has
pan?
this patient has no current addictions.
Does he have any sharp tooth or
No,
any
ma'am.
dental procedures which has been done?
No recent dental procedures or no sharp tooth present.
Nothing was there.
No.
Is he alcoholic?
No, ma'am. He is not an alcoholic, ma'am.
Okay, right. Did they have the habit of chewing quid?
No quid, ma'am. It's only pan masala according to the patient.
What is quid, by the way?
It's a chewable form of nicotine wherein it's kept in the gingiva-buccal sulcus over as a part of practice.
It is just a chewable part of nicotine. Nicotine per se, does it cause malignancy?
Yes, ma'am. The byproduct of nicotine metabolism of nicotine causes the malignancy. Ma'am.
There should be some offending agent which should traumatize the mucosa there, no? What is the thing which is present in the quid? So what are the components of the quid? It's a betel leaf
Betel
along with a betel nut or areca nut along with the nicotine.
nicotine.
Okay. And one ingredient which is there, which is the one which is a major culprit fellow who tends to damage your mucosa. Who is that?
Alcohol.
Alcohol. Alcohol potentiates.
Yes.
In the quid, you have something. They will tend to add, that gives the color to the tongue when the patient eats that pan. It's a flaked line. Okay. We call it chunambu in Tamil. I don't know what is it in Hindi, right? So that is the
We
major
call it
culprit.
chuna in Marathi too.
Okay, ma'am. Nice. Right? So that all these things have been wrapped as a pan and it has been chewed and it has been kept in the oral cavity. And how long does he keep it?
Some people
Half
tend
an
to
hour, 1
keep it
hour?
overnight.
Huh?
Some people tend to keep it overnight also.
Yeah, very good. So he tends to keep it overnight, and what he does it during the night time? He tries to bring it back into the oral cavity, chews it and takes it back and put it back again in the sulcus. Okay. From where this term quid arrived? Quid is nothing but the ruminant sac which is being hanging down in front of the neck in the animals. You would have seen lot of cattle who would be grazing. They tend to eat the food and they will collect it in the pouch, right? So whenever they feel hungry, they bring it back inside the oral cavity and they tend to eat it. Similarly, these people will put it in the sulcus. So that's the term which came from this, on seeing this cattle, right? So quid is coming from that, right? Coming on to the past history, you have asked about low dose irradiation in childhood, right?
Yes,
What do you mean by what do you mean low dose irradiation?
Less than 20 gray X-rays are called low dose irradiation. Ma'am.
Okay. So the duration of exposure should have been very long period, right? Say about almost for about lot of sort of 10 to 20 years ago, then the 20 gray radiation which has been exposed, right? This is called as a low dose radiation. What will happen when you have a high dose irradiation?
There will be the ablation of tissues instead of the mutative behavior of the low dose.
Very good, right. You have asked about cancer related deaths in the family. Any family history, is there a link to oral cavity malignancy?
There are a couple of genetic background for the oral cavity, ma'am. When there are mutations in the MYC gene or RAS gene.
Okay.
So, but in this patient, there is no cancer related deaths.
Okay, we'll go on to the personal. Next slide. Okay. Regarding smoking and alcohol, where have you mentioned? Next slide.
No addictions currently, ma'am. Only the history of chewing pan masala that was 15 years ago.
But you should mention the addictions currently means we are not sure whether the patient was a smoker or a non-smoker, whether he's an alcoholic. All those things are must in this case, as because these would be the risk factors for this patient, right?
Yes, ma'am.
When there are specific risk factors, you need to mention about those things, right? Rather than putting as no addictions currently. This addiction might be a mobile addiction also,
Yes.
which may not be relevant for your case, right?
Okay.
So be specific regarding the risk factors. Right.
But I have a
We'll go-
question. Why he asked for the bowel and bladder habits are regular?
That's
No, whenever you are presenting a case, there is no template like this. You should customize to your this particular patient why you want to ask that particular history. In what way? In any way it is related to your case?
no, ma'am.
Then why are you asking? You should customize your history. What is important in this particular, like now no history of alcohol intake or no history of like that. That is enough.
Okay.
Do you get a loss of weight in this patients? Loss of weight, loss of appetite?
It is rare in oral malignancy, ma'am.
Ah.
It is usually seen in GI cancers or ovarian malignancies where there are large volume tumors.
Very good. So usually when you have a large volume tumors, the tumor necrosis will lead on to a loss of appetite, right? But here in case of a oral cavity malignancy, generally you don't tend to have a loss of weight or an appetite. But still our patients, they do have some difficulty in eating when they have this halitosis, this bad breath, right? They find it difficult to eat, and moreover, when you have a trismus in advanced cases, these patients will not be able to eat and they will attribute it as a loss of appetite. Okay.
Yes.
Right. So you should be able to differentiate whether it is because of the appetite which is lost or the mechanical hindrance which is causing this.
Loss of appetite.
Okay. Right. Difficulty in eating. Right. We'll go on to the next slide. So from your summary, what is your diagnosis?
Given the complaints of non-healing ulcer for 2 months in the oral cavity and the history of chewing pan masala, I suspect oral malignancy of the oral cavity.
Okay, if a patient is not having the habit of chewing pan masala, in that case, what would be the differential diagnosis? What are the other causes of ulcer within the tongue? Not in the tongue, not in the oral cavity.
Painful ulcers or aphthous ulcers or
Okay.
because of dental sharp tooth or dental.
Okay.
dental.
So patient can have a dental ulcer or an aphthous ulcer, or it could be a pyogenic granuloma,
Yeah.
which is occurring there, or it could be a syphilitic ulcers, right? Okay. Was the ulcer in your patient was painful or painless?
It's a painless ulcer for the patient, man. But in the examination, when we started examining the patient said it was tender.
Tenderness is patient can't say. You have to.
Like when we are examining, he complained of it.
No, it should not be a verbal one. You should appreciate it from the patient face, the discomfort, and say whether he's actually having tenderness, right?
Tenderness is a sign, no? It's not a symptom.
Yes.
You need to ask the patient is a complaint, something like that, right? But tenderness is one thing when you need to observe from the patient face, right? And see whether the patient is feeling difficulty or some discomfort, then you can document it as tender, right?
Yes.
Okay, we'll go on with the examination.
On examination, I examined the patient in a well-lit room with adequate exposure, and after taking an informed consent, patient is conscious, coherent, cooperative, and comfortably sitting. well hydrated, well built and nourished. ECOG score is 0. BMI is 26.4 kilograms per meter square. The vitals, the pulse rate was 84 beats per minute. Um, respiratory rate was 17 cycles per minute. BP was 130 by 70 millimeters of mercury, and he's afebrile. There is no evidence of pallor, rectus, cyanosis, clubbing, koilonychia, pedal edema, or generalized lymphadenopathy in this patient. Examining.
Why do you want to look for koilonychia and the patient is not pale? You said no pallor.
Yes, sir.
You want to reinforce that there is no is not anemic. Okay. Go ahead with the examination.
Examination of the head and neck. On inspection, there is a fullness noted over the right cheek, 3 centimeters anterior to the angle of mandible with smooth surface, no skin changes, scars or sinuses. And the skin over the swelling is normal. The mouth opening is 6 centimeters. Oral hygiene is maintained. The staining of teeth is present. Lips are normal. A solitary 2 by 1 centimeter irregular ulcer is present.
Just a minute. What is his complaint?
Ulcer over the.
And why are you not examining the inspection ulcer the first? Examining the ulcer first. That should be the first thing, followed by the oral cavity, opening mouth, everything, no? You first, whenever what is the complaint, you examine that first. Followed by the fullness, everything. That will be on the secondaries only.
Yes.
Patient, is the patient complains of a fullness in the cheek?
No.
No. Then first you tell the ulcer. Examination of the ulcer first.
Yes, no. A solitary 2 by 1 centimeter irregular ulcer present in the right gingivobuccal sulcus below the second molar tooth with surrounding erythema and gray slough present over the ulcer with raised and everted edges and no active discharge. All teeth are intact with no sharp or loose teeth. Retromolar trigone is paired. Gingivobuccal sulci are normal. Tongue movements, floor of the mouth are normal. Hard and soft palate are normal. No anterior and posterior pillars and tonsils are normal. Uvula and posterior pharyngeal wall are normal. No swellings noted in the neck.
What is the extent of the ulcer?
It's 3 by 2 centimeters ulcer from the below the second molar tooth, ma'am.
Extent. Anterior extent, posterior extent, upper limit.
But I
This
think you
ulcer, you
mentioned
need to
2
tell-
by 1 in your slide.
Sorry, ma'am.
I think you have
See,
mentioned the ulcer size as 2 by 1 in your notes, in your slide, not 3 by something.
Go to the previous slide. You are written 2 into 1. Now you are telling 3 into 2. That's what madam is asking.
3 by something.
Sorry, ma'am.
See, whenever you have an ulcer, you
So
need to
what is
say
it
about the
doing?
dimension, and you need to say how far it is from the retromolar trigone and how far it is from the angle of the mouth and how far it is from the lower alveolus and how far it is from the upper alveolus if it's too high, right? So that you know about the extent. Rather than just saying it's just a 2 by 1 centimeter ulcer. Always extent is a must. The site, size, the shape, the surface, and the extent are the first 5 points. Right?
Yes,
You need to talk about
that is
it.
all going to decide your management.
And I am not able to understand what is below the second molar tooth.
it is situated beneath.
You mean to say the ulcer is present over the alveolus? Is it so?
In the gingivobuccal sulcus corresponding to the second molar tooth.
You are
Okay.
telling at the level of the second molar tooth. Lower or upper?
Lower jaw, ma'am.
Nothing written like that, no?
Yes, ma'am.
You didn't mention about the extent, whether it extends up to the gingiva or
Is the retromolar trigone free or it is reaching the retromolar trigone?
It's spared, ma'am. It's free, ma'am.
It's fair,
How far
yes.
it is from the retromolar trigone?
Most 2 centimeters from the retromolar trigone, ma'am.
Almost 2 centimeter.
Yes.
Looks little difficult to me because it is already on at the second molar.
molars near the retromolar trigone, no? So it is always better to follow the basic steps like extent. If you are told the extent properly, you'll be able to understand it better.
Okay.
Because when you see the second molar tooth, after second molar comes your third molar. Immediately after the third molar, your retromolar trigone area is going to be there. You said it's almost
So 2 centimeters it
starts,
can't be.
right? So
Just
your
about a centimeter maybe.
2 centimeter, the distance is not. It will be, the distance might be a little bit smaller, right? It won't be so far apart, right? As you imagine. So you need to be very specific regarding what is the dimension. It's always better said what is the extent according to the landmarks. The landmarks is always the retromolar trigone posteriorly, anteriorly it has to be the angle of the mouth, and above and below it's going to be your sulcus. Is
Okay.
it clear? Right. Okay, we'll go on to. So initially you started with presentation on the exterior surface, right?
Yes,
But
ma'am.
as madam said, you always complete with the patient. What was the patient complaint? So the patient says there is an ulcer, start talking about with the ulcer. But the first point you can say whether the facial asymmetry is present or not present. Okay, if that means we can infer that there is something which is present outside. So that can be said on inspection. And after that, you talk about the mouth opening, right? You said the mouth
Okay.
opening, it was around 6 centimeter. So
Yes,
in what conditions the mouth opening would be restricted?
Submucosal fibrosis, if the patient develops the secondary type of submucosal fibrosis, or
Good. Then
involvement of the retromolar trigone and temporomandibular joint.
okay.
Involvement
And
of the
involvement
masseter
of
muscle.
something else.
Masseter muscle.
Theta involvement, pterygoid involvement.
Okay.
Okay, all these things will not allow you to open your mouth freely. Any medical condition which will have trismus?
Tetanus.
Tetanus. Any other condition, non-malignant condition which will have a difficulty? A peritonsillar abscess, a quinsy. We can have a trismus. Okay. Fine.
Yes.
Did you talk about nicotine staining in the oral cavity on your inspection?
Staining is present, ma'am. I mentioned it in the inspection.
You mentioned it earlier, right? You said oral hygiene is main thing, but staining of the teeth is present. About the staining in the cheek, nicotine staining, whether it is present. You have not mentioned, right?
I just have one question. Maybe it's going back to the next part. You are seeing that staining of the teeth is present. Have you confirmed from family members whether he has really stopped eating tobacco?
I didn't ask the family members, ma'am.
Because why should his teeth remain stained after stopping tobacco for so many years?
That too, he told the patient
I
age
think you
is
should do that.
32.
Yeah.
Patient age is 32.
Okay.
But, 15 years back, he had tobacco. So it means the patient had pan chewing at the age of 17 or
The
16.
patient was about,
Yes, ma'am.
yeah, even younger than that. Yeah.
You didn't ask why he stopped?
Okay,
Yes,
go ahead.
yes, ma'am. Apparently, he said when he was at that age, he was unemployed and he had those habits, ma'am. Later, he joined as a receptionist and he stopped using all.
Have you looked
Okay,
for
tell
any pre-malignant conditions on
Uh,
inspection in the oral cavity?
There are no erythroplakic or leukoplakic patches in the cheek. ma'am.
Not on the same side. Any other side of this mouth?
Yes, ma'am. Yes, ma'am. In the
But
oral
you didn't mention it in
cavity.
the slide, no, on inspection.
what
Okay.
are the pre-malignant conditions?
Uh, They are divided into high risk, intermediate, and low risk, ma'am. High risk are erythroplakia, uh, varicose leukoplakia, and uh, candidiasis, ma'am, hyperplastic candidiasis. Intermediate risk
Okay,
is submucosal fibrosis, ma'am. And
okay,
low risk are oral lichen planus and discoid lupus.
okay. Right. What are these clubbed together nowadays? And it's not called as pre-malignant or precancerous conditions as earlier. How they are called now? Potentially malignant conditions, right?
Okay.
That is the terminology which is being used now.
Okay.
Right. What are the types of leukoplakia?
Leukoplakia, there are homogeneous and non-homogeneous types, ma'am.
Very good.
Homogeneous is a smooth plaque, and
Good.
non-homogeneous are of two types, ma'am. That's nodular and verrucous.
And speckled leukoplakia is
Speckled
also there.
leukoplakia.
Okay.
Out
A
of all,
person that what is the percentage of a person having a leukoplakia to develop malignancy? Will all persons develop? Around 6 to 7% only will go in for a malignancy, right? Among these precancerous conditions which you have listed, potentially high risk, which is the most deadliest one?
erythroplakia, ma'am. But recently, combination of erythroleukoplakic patches are carry more risk of development of cancer.
Very good. Yeah. What is the site for this chronic hyperplastic candidiasis? Where do you get it?
The angle of the mouth most.
Okay, good. Right. Tell me the boundaries of oral cavity, inner aspect.
It's the vermilion border anteriorly, anterior tonsillar pillars posteriorly, and the inner surface of the cheeks laterally.
Superiorly?
Superiorly, the hard palate.
Yeah, junction between the hard
Hard
and the
palate and
soft
soft
palate.
palate. And inferiorly, the circumvallate papilla of the tongue.
Okay. How do you differentiate between the lip and the cheek on the external surface?
The nasolabial fold is considered as the boundary for the lip and the cheek.
Yeah, very good. So any lesion which is pertaining only to the angle of the mouth and it's going inside or from the inside it is reaching the angle of the mouth, this has to be clearly got from the patient where the lesion started. Whenever you have a bigger lesion which is involving the angle of the mouth, okay? So that is the reason why I asked this question, whether it is starting from the cheek or from the lip. You should be able to differentiate, right? Right.
Yes.
So can we move on to palpation?
Yes.
Okay. Regarding you didn't talk about any induration around your ulcer. Okay. Was there any induration noted?
Excuse me, ma'am. I'll be talking about in the palpation, ma'am.
You have not started palpation.
Ma'am, inspection is just done. I'm just starting on palpation.
Okay, start.
Madam, lip carcinoma extending into the oral cavity, do you consider as oral malignancy?
No, sir. From lip it started, it's only starting from the lip, it's the carcinoma of the lip only.
Because carcinoma oral cavity lips, they are not included, isn't that, Miss? Not, madam?
Nowadays, it is not included, sir. Earlier, it was there, but now lip is coming as a separate entity. But just
Yes,
for
ma'am.
examination's sake, I wanted to know so that
Hmm.
whether it is starting from the lip and going in, or it's coming from out to coming inside,
But
inside out
vice
or
versa-
outside in.
But vice versa is oral cavity malignancy. Coming
Yes,
from the
sir.
oral
Vice versa.
cavity into the lips. Yes.
It is oral
Then I had
cavity
a doubt.
malignancy.
I had a doubt.
Everybody had this doubt, sir. Thank you, sir. Right.
You're welcome, madam.
Thank you, sir.
Carry, Sarath.
Yes, sir. On palpation, the fullness is tender on palpation with no local rise of temperature. The inspective findings are confirmed with a 2 by 1 centimeter irregular ulcer in the right gingivobuccal sulcus below the second molar tooth, with surrounding erythema and gray slough over the ulcer, raised and everted edges, underlying soft tissue as base, and no active discharge. The induration extending 1 centimeter around the ulcer. There is tenderness present around the ulcer, no sharp or loose teeth noted. The rest of the gingival sulci and the oral examination are normal. Examination of the neck, a solitary while discrete.
Just a minute. Go to the previous one. Previous one. You told underlying soft tissue as a base, but you told it is gingivobuccal sulcus, no?
Yes, ma'am.
There is no induration at the bone or on the...
There is 1 centimeter induration around the ulcer. Ma'am.
Or the alveoli, there is no induration.
There is an
Only
excellent
underlying soft tissue as the base. Go to the next one, next slide. And you are telling indurations extending 1 centimeter around the ulcer. Then it should be around the alveoli, no? Medially.
Yes, ma'am.
Now you cannot say like that, no? It's better it is indurated.
Okay.
Base is indurated.
This is okay, ma'am.
Your
Yes, the
examination
base
findings and your presentation should be like an undergraduate. There should not be no extra adjectives like that. Then you can proceed on the discussion like a postgraduate.
Okay.
So is the induration the base or the surrounding area?
It's in the surrounding area as well as the base, sir.
So what does it implement to you? There's induration and tenderness present around the ulcer. Do you know the reason for the induration? Why it is big? What is induration? It's nothing but just an extra thickening from the normal area. You feel some thickness. It may be tender and indurated if there is any surrounding inflammation. And usually in malignancy, what reaction? There's something called desmoplastic reaction.
Yes.
You heard about it. So that also will lead on to induration. So that implicates the ulcer is growing. It is not static, it is an extending ulcer. So in the palpative findings, you know that the ulcer is not confined to that area. It is extending to the surrounding area also.
Yes, sir.
Yeah.
Yes, sir.
See, even in inflammation, you will be seeing this induration, right?
Yes, sir.
So sometimes when you see an abscess, what happens? You'll see the abscess will not be confined to that area, right? The surrounding skin, everything would be involved, right? There will be a thickening. So try to look for this induration, right? How far the disease process is going on.
Yes, sir.
Right. Regarding the induration, are you able to appreciate the depth of invasion in your tumor?
No, ma'am. Due to the tenderness, I couldn't examine the ulcer.
You couldn't palpate?
Yes, ma'am.
Why the ulcer is so much tender? You should be gentle in your palpation. You cannot say that since the ulcer is tender, I am not able to examine it. Only if an abscess, you can say like that. Not in a malignant ulcer.
Okay.
Is that
Sometimes-
serious? Is it severe discharge from the ulcer? Is it in reddish in color?
No discharge, sir. It has grayish slough covering over the.
So the ulcer cannot be tender.
Sometimes what happens is the patients might be a little bit choosy. They
Choosy,
will
yeah,
be showing as if it is tender, right? They won't allow you. So you need to convince your patient, you need to talk with them, and then you can palpate and you'll be able to identify it, right? So what's the difference between this tumor thickness and depth of invasion?
Depth of invasion is the depth of the tissue reached from the surface of the mucosa, ma'am. The thickness of the tissue is the overall longest dimension of the involved tumor, ma'am.
I didn't get it. Come again?
The depth of invasion is the depth from the level of the mucosa involved, ma'am.
Actually, the depth of invasion is almost pathological. From the basement membrane, the distance how far it goes below is considered to be the depth of invasion.
Depth of invasion.
Clinically in your TNM, it says to be, you need to look for depth of invasion, right? So when you try to palpate the thickness and you try to appreciate in an ulcerated lesion, the depth of invasion. Whereas when you have a proliferative lesion, from the mucosal surface, the lesion which is coming above, that would be the tumor thickness. Okay, that will not be equated to your depth of invasion, right? So depth of invasion can be clinically determined in lesions of the tongue and buccal mucosa, wherein you'll be able to do a bidigital palpation, right? Whereas when you have a palate lesion or any alveolus or those areas, you'll not be able to do this bidigital palpation, wherein you'll not be able to determine your depth of invasion, right?
Yes.
Right. Next slide, ma.
Examination of the
Okay.
neck. There is a solitary mobile discrete lymph node of size 2 by 1 centimeters in the level 2 of cervical group of lymph nodes, which is non-tender, firm in consistency noted. There is no other swelling noted in the neck.
Which side?
On right side, sorry, sir. Sorry, sir, that's on the right side.
What do you mean by level 2?
Level 2 are the upper jugular lymph nodes, ma'am.
Have you looked for mandibular or submental?
Yes, ma'am. Submental and submandibular lymph nodes also have checked for, ma'am.
Since it's a gingivo-buccal sulcus, should be the submandibular group which should be involved first, no?
Yes, ma'am, but
Firm in
clinically,
consistency or hard in consistency?
it's firm in consistency here.
So can it be a non-malignant node?
It can be a non-malignant node in clinical examination also, ma'am.
Okay, we'll come to
Nodes
that.
are
How will
usually
you-
hard to.
But
We'll come to that after.
non-tender also. Yeah.
But your lymph node is not tender, but your ulcer is tender.
Yeah.
Okay. Right. But you never talked about your mandible examination. You gone to the neck. Have you mentioned about the mandible? Did you palpate it?
I palpated, ma'am, but there is
Is there any thickening, any enlargement of the tables, outer table?
no,
Any
ma'am.
crack? Nothing was noted.
No,
Nothing.
on inspection you told there is a fullness in the cheek,
But
no?
that's
Yeah.
what.
No, he has not palpated the cheek. In
Hmm.
fact, the ulcer in the photograph also seems to be extending onto the buccal mucosa very, very clearly. It's not only over the alveolus. So have you
You're not done
palpated the
any
cheek?
bimanual palpation, I think. You know the depth of the ulcer.
He has not mentioned anything about that part.
Because for such a small ulcer, 2 into 1 centimeter, that should not be any fullness or swelling on the cheek, no? On the outside.
Yes, ma'am.
when you have such a big swelling on the external surface, inside you have a very small ulcer. That means you need to palpate and see whether there is going to be some tumor or anything which is sitting onto the buccinator muscle, like that. You need to palpate and check it out, right?
Yes, ma'am.
You are set in the gingivobuccal sulcus. So
Yeah.
definitely through the alveolar sockets, some amount of things would have gone into the mandible. So check the mandible. Okay. When you said there is some swelling in the exterior, you can put your finger, one finger inside, one finger outside. You can palpate the ulcer. You know whether the induration has extended onto the external surface. If not up to the skin or up to the subcutaneous tissue. So clinically, you'll know whether it has pierced the buccal pad of fat, buccopharyngeal fascia, the muscle, the pharyngeal fascia, the subcutaneous tissue. So you may know the depth of how much is it indurated.
Yes.
And when you, in this gingivobuccal sulcus, you have to definitely palpate movement of the mandible. Put your fingers under the mandible. Look for any irregularity, any thickening. Okay. All these things you should. Mandible examination was done. You can say normal. That's what was Madam asking.
Yes, sir.
Okay. Was the temporomandibular joint normal?
Yes, sir.
Moment. Okay. So did
Okay,
you
what's
examine
your-
the opposite side of the lymph nodes? Opposite lymph nodes?
Yes, sir. Contralateral lymph nodes have also been examined, sir. There is only one palpable lymph node present in the neck, sir.
Opposite side also.
Yes, sir.
Why you written no other swellings noted?
You go to the next slide.
What are the swellings you are expecting?
No other palpable lymph nodes.
That should have been better, no?
Yes, sir. No other palpable lymph nodes present in the neck.
There's no other
The
swelling should
notes
have been in the
palpable, that's
history.
enough.
Okay.
Okay, it should have been in the history there, right? Here you could say it is the no other lymph
No
nodes
other
palpable.
palpable lymph nodes.
Right.
And
Okay,
this
we'll go on.
CVS, RS. RS is okay because the oral malignancy will go in for aspiration and other thing problem. Whereas abdomen, why? It is not a, it's a locally invasive, it doesn't go to the distal spread is very less.
Yes.
Focal neurological deficit. You can very well put it in a shut shell, other systems clinically normal.
Okay, sir.
What's your diagnosis?
Diagnosis is carcinoma of the right gingivobuccal sulcus with ipsilateral level 2 lymphadenopathy with clinical staging of T2, N1, and MX.
Clinical staging, you won't write as MX, you'll write as M0 only.
Okay.
When will you write it as MX?
And they are not assessed. Distant metastasis is not assessed.
Yeah, after all investigative procedures, you cannot trying to do any assessment, huh?
Yeah.
Okay. How do you want to proceed in? Why do you say it's a T2 stage? This thing.
Yeah. Investigate. How will you manage this patient?
No, so first before that, why do you say it's T2?
T2.
Oh, sorry.
Size greater than or equal to 2 centimeters, 2 to 4 centimeters come under T2.
No, you told 1 into 2 centimeter also, no? Up to 2 it is T1, no?
Yeah.
Less than 2, it's T1, and 2 to
Up
4
to 2 it is T1. Have you measured with the inch tape proper?
And what's the
Their
depth?
approximate length?
And you're not include the local invasion.
He has
into
not
the
mentioned
cheek.
the depth of the
Local invasion into the
depth
cheek.
of
No.
the ulcer. He has not mentioned.
In that case, what would be your staging now?
2 centimeters.
See, definitely there will be a mandibular involvement in your case, right? There is a cheek bone which is enlarged. So definitely it would be T4 disease.
T4, if it's
It won't be a T2 disease, right? If the cheek, mandible, and other things are going to be flat and it's going to be normal, and if there's an ulcer which is going to be less than 2 centimeter or more than 2 centimeter, according to you, it's only 2. Less than or equal to 2, it comes under T1. That's what madam was telling you now, right?
Yes, sir.
So clinically it may be T1, but actually we don't know.
Actually, right. Okay, how do you want to proceed in this case?
To confirm the local extent of the tumor,
Mm.
an pantomogram can be done, ma'am.
You don't want to confirm your diagnosis, whether it is
With
malignancy or not?
with the edge biopsy should be taken, ma'am.
Why you want to do a edge biopsy?
Edge biopsy should be done at the anterior margin of the ulcer, including the normal tissue, ma'am.
Why anterior margin? Why not posterior?
Posterior margins, the site of edge biopsy should be included when the patient is taken for surgery, ma'am. So posterior edge biopsy.
No, you are taking the edge of the ulcer, no?
Yes, ma'am.
Edge of the malignant tissue only you are taking, no?
Yes, ma'am.
So whichever is feasible, it's okay.
See, usually the one which is anterior will be easy and amenable for doing a biopsy.
That will be
Don't
better.
talk about okay, right? You need not specifically mention that I'm going to take it from the anterior wall or the posterior wall. Just say I'll be taking a edge biopsy, right?
Yes.
From the edge of an ulcer. That's it, right?
Yes, ma'am.
Okay. What are the various biopsy?
Yeah, oral cancers, which biopsy is better to know the? There's something called the staging where you're included DOI.
Yes, sir. That recently punch biopsy has also been started for oral malignancies to know the depth of invasion, sir.
So because here there is induration and you see a swelling in the cheek, the edge biopsy will give you the pathology, but the depth of invasion is done by the
Punch biopsy.
so why don't you add that also? Okay, yes, madam, please.
Okay. What are the various types of biopsies you get in oral cavity malignancy?
Various types of biopsies.
Various types of malignancies. Here, what do you expect? What will be the biopsy report in your case here?
It is a squamous cell carcinoma, ma'am. Keratinizing
Okay.
squamous cell carcinoma.
Right. What are the other types of malignancies which can occur in oral cavity?
Verrucous carcinoma.
Okay. Then? Any glands which are present in the oral cavity? Minor salivary glands. You can have tumors from the minor salivary glands. You can have melanomas. Sometimes you can have also sarcomas from the oral cavities, right? So these all would be the differential biopsies you should be aware of, right? You should not always think it was going to be only a squamous cell carcinoma, right? So what is the biopsy report you got in your patient?
Biopsy report is really, I mean, you all read it, but it is, I don't know whether this is the way the report should be given.
Biopsy, they have written advice to correlate with clinical and radiological finding.
Yeah, and look at these features are suspicious of invasive keratinizing squamous cell carcinoma. What is suspicious?
Inherited keratin pearls are there.
Yes.
And you told verrucous carcinoma is a type of carcinoma. What is the type of carcinoma in verrucous?
Comes under what category?
It's an exophytic growth.
No. When madam is asking what are the types of cancer, you can get it in the oral cavity. You are telling verrucous is a type. Verrucous is a type, malignant, histological type.
Of what cancer? Is it an adenocarcinoma or something else?
Squamous cell carcinoma.
Usually it is a well-differentiated squamous cell, no?
Yes,
it's not a separate entity.
Yes, ma'am.
Hmm.
Okay,
Now
how?
you're telling.
Okay, we'll accept that your biopsy report says it's a squamous cell carcinoma, which is of an invasive variety, right? We will not go into the report discussion, right? Fine. What do you want to do now?
Have you taken any FNAC from the lymph node?
No FNAC was taken from the lymph
Why?
node.
How will you know whether it is malignant or non-malignant? Any other method to differentiate whether it is a malignant or non-malignant?
Ultrasound findings can also be.
It will be a confirmatory one. What are the malignant features in ultrasonogram?
Uh, a loss of the halo
So
around
starting
the
from the size, shape.
shape it's more rounded off compared to the bean shaped of normal.
Not bean shaped.
From bean shaped, it is round shaped, number one. Okay, loss of fatty hilum.
Loss of fatty hilum, central necrosis, hypoechoic central.
Hypoechoic central, then taller virus. You get there. Increased vascularity. The size of the node is more than 10 millimeter. 10
Okay, having done a
millimeter. These are the
biopsy
features
now,
suggestive of malignancy.
Yes.
Pardon, madam?
no, how to proceed further, கேக்குறேன் sir. Time போயிட்டு இருக்கு.
Yeah, it's time getting time up. So you have a
That's all.
one node with MX. Any other investigation of choice will you do?
Contrast CT of the neck, sir,
Why?
to know the extension of the local tumor and the lymph node status of the neck.
Yes.
Will you prefer a contrast CT or an MRI?
Yeah.
My patient, it is involving the gingivobuccal sulcus with, so I prefer a CT to know the mandibular involvement, ma'am.
Mandible is
Very good.
involved or not?
Yes, sir. In this patient, it is involved, sir.
Partial involvement or complete involvement? Is the outer cortex or inner one also? Is there a fracture? Is there a totally involvement?
There is no fracture, sir.
So you don't know. Say, okay.
Yes.
With these findings, what would you like to, how do you proceed further?
The involvement of mandible, I go for composite resection with modified radical neck dissection.
You have not done a FNAC of the lymph node.
No.
Maybe a non-malignant. Firm node, non-tender, only 1 into 2 centimeter. That to level 2. Okay, what is composite resection?
There is removal of the involved mucosa along with the resection of the mandible.
How much
What type
mandible
of-
will you remove?
We have been asked to close in 5 minutes. You tell me, will you straight away go in for surgery or an upfront chemotherapy or a radiotherapy? Mandible is involved. You tell me points in favor, chemo or radio or surgery first.
I'd go for a surgery first in this patient, sir, and there
Why
are.
Why not radiotherapy?
I gave you the clue, radio, chemo or why not radiotherapy? If you're giving radiotherapy, why not radiotherapy?
Mandible.
Already you said the mandible.
That you have to read. Certain involvement of the mandible, radiotherapy is contraindicated.
What will happen when you give a radiation to the mandible?
There is a osteoradionecrosis of mandible, ma'am, because of the involvement of endarteritis of inferior alveolar artery.
Okay. You do a surgery, then how do you follow it up? Madam asked, what is composite resection?
Resection of the mucosa along with the mandible and
And followed by
So
cover.
you have
What
a
is the cover you are going to give?
mandible.
Always when you do a composite resection, you need to talk about the cover,
yes,
right?
ma'am. Yes,
Ah.
ma'am. With free flap, most commonly used pectoralis major myocutaneous flap.
What will happen to the mandible? Gap in the mandible.
A free fibular flap can also be used, which covers for the defect of the bone in the lower jaw.
Nowadays, more number of prostheses are available, no? Apart from fibula. Depending upon the length, there are many number of prostheses. Plates are available. You can cover the mandible gap with the plates followed by the free flap. That will be better option, no?
Yes.
Okay, tell me a few points about your modified radical mastectomy. What type of modified radical mastectomy you want to do? So that we can close this session.
Neck dissection, modified radical.
Sorry, modified radical neck dissection. Sorry.
Okay.
Mandible, that's what if it is of segmental and involvement of the outer cortex alone, you can do a segmental marginal mandibulectomy along with the tumor. You can give a cover to the skin, subcutaneous tissue, and you can give a bone graft. If it is involved totally, then only you go in for a composite resection. You remove the whole tumor along with the mandible, reconstruct the soft tissue, and also reconstruct the, as madam said, with the bone. Or you have the madam said something, if I suddenly couldn't get. Okay.
If you are able to retain the mandible of 1 centimeter height,
yes, madam,
then you can go ahead with the marginal mandibulectomy. Okay, of an uninvolved mandible, you have to leave it behind. If you're not able to do that, then you need to go for a segmental mandibulectomy or a hemimandibulectomy. Otherwise, a marginal mandibulectomy would be sufficient, right? What is the shape you will take up when you're going to do a marginal mandibulectomy? How does it look like? It comes like a boat shape, right? Right? When you do that, the fractures of the mandibles are less. Whereas when you're going to do a straight cut like a Tana like this, then the fracture segment will happen, right? So in order to avoid that, usually they take it in the bone saw like a curved fashion, like a cano.
Yes.
Right? Okay, what is the role of a post-operative RT in your patient when you do an upfront surgery?
If there is R1 is like if the margins are positive.
madam was asking a question. What are the
Sir?
what Babita madam, you asked some questions.
Yes, sir. What type of modified radical neck dissection he'll do?
Which type? 1, 2, 3. That's the question.
Will you do a functional or modified radical?
Involving level
Or
2
supraomohyoid?
to even clear the sternocleidomastoid, no?
Okay.
So
if the node is negative on the right side, it's a reaction node, you can go in for a functional modified radical neck dissection number 3. A supraomoid, this one, since you said level 2, you can do a functional neck dissection. If the node is involved, then you can do a modified radical neck dissection.
yes.
Am I correct, madam?
You got the point, huh? Yes, sir.
Yes,
So
sir.
even in the presence of a negative node, but clinically you think it's a positive node, right? But FNEC wise, it is a negative node. But what happens when post-operatively, sometimes this node might also be a positive one. How does it become positive? That is called as a geographical miss. You'll not be able to target the exact lesion, right? While doing an FNAC, right? So it might be positive. That is why an elective neck dissection, even the presence of a N0 nodal disease, has to be done in the presence of an oral cavity malignancy.
Okay.
Any doubts you want to ask?
Well, something you have to just brush it up. You go and read about the indications of post-operative radiotherapy. We have indicated chemotherapy. When do you give upfront chemotherapy? And how does it spread oral cancer? As madam said, will you get halitosis or
Yes, sir.
excess salivation? In all these things should be pertain to your case you present. Okay. Otherwise, a
Yes.
good presentation. Good luck.
Yes.
Would you like to ask any doubts or questions to the examiners?
No, sir. Thank you, sir.
Right. Next time, take up a case of see a tongue and present. You'll know the difference.
Yes, sir.
Thank you.
Thank you.
Thank you.
Thank you, sir.
Thank you,
Thank you so much.
Srinivasan sir. Thank you all the faculty. I think Karnakaran sir also joined. Thank you, sir. Sarath, thank you very much.
Thank you, sir.
So please make a note of all
Karnakaran
these
sir, vanakkam.
points in a piece of paper,
Yes, sir.
and then
Thank
you
you.
can go and update. Within a day or two, you get back to the library and fill up the remaining areas of knowledge gap. All right.
Yes, sir.
Good luck to
Thank
you.
you, sir.
Can we have Mohammed Suhail here?
Yes, sir.
Okay, settle down, settle down. Yeah. Okay, Mohammed Suhail, please introduce yourself, your unit chief, head of the department, and start your presentation. Thank you very much.
Yes.
Good luck to you. Faculty, please take over.
Thank you.
Make it slideshow, huh?
Thanks. Good evening, respected faculties. I am Mohammed Suhail from Coimbatore Medical College, final year postgraduate MS General Surgery PG. My HOD is Dr. T. Srinivasan sir. My chief is Dr. Muthulakshmi madam. My assistant professors Dr. Kavita madam and Kunal Suresh sir. Coming to my case, my patient is a 45-year male patient who is a farmer by occupation from Coimbatore. Came to the OPD with the chief complaints of swelling below and behind the right ear for the past 8 years. Coming to history of presenting illness, patient was apparently normal before 8 years. Then he developed swelling below and behind the right ear, which is insidious in onset, slowly progressive in nature to attain the present size. There is no history of increase in size of the swelling during chewing. There is no history of pain over the swelling. There is no history of pain to the ear. No history of fever. There is no history of difficulty in opening the mouth. There is no history of trauma. There is no history suggestive of facial nerve palsy such as difficulty in closing the eyelids, difficulty in opening or closing the mouth or chewing the food. There is no history of deviation of angle of mouth or no history of drooling of saliva. There is no history of loss of weight, no history of loss of appetite. There is no history of similar swelling in the opposite side like other salivary glands. There is no history of dry eyes, dry mouth, and joint pain. Coming to past history, there is no history of similar swellings in the past. There is no history of recent major illness or major surgery. Is not a known case of diabetes, hypertension, or cardiovascular disease, renal disease. There is no history of mumps in the past. There is no history of radiation exposure in the past. Personal history: patient takes mixed diet. His sleep and appetite is normal. He is a non-smoker and non-alcoholic. This is the clinical picture. Coming to the summary of my history. My patient is a 45-year male patient with complaints of slow-growing painless swelling over the right parotid region for the past 8 years with no history suggestive of facial nerve involvement.
What is plus? Let the examiners take over.
Yes, sir.
Yes, madam. Anandi, madam.
Yes, sir. I'm here only. I'm just looking into this. So this patient has got a swelling.
One small suggestion. What is here?
Yes.
Whoever is the presenter, when you present this one, you put a small picture on the beneath. So we
Okay,
can
sir.
have a clinical picture view of it.
Okay, sir.
Okay. You put a
Okay,
picture.
sir.
I told you to add a picture here.
Ajay Khanna sir, thank you, sir. Thanks for joining in spite of being in a conference. Thank you, sir.
Thank you, sir. Sir has come.
Thanks. Welcome, sir. So this patient has got a swelling below and behind the right ear for the past 8
Yes,
years.
ma'am. Yes, ma'am.
Okay. It's for the past 8 years, it is so slow growing, so that it's still stuck there. It does not come up. Okay, right. We'll go
Yes,
on to the
ma'am.
next
Yes,
slide.
ma'am.
So which are the swellings which at that site can be insidious in onset?
Lymph nodal swellings,
Lymph
any
nodal swelling.
parotid swellings, any lymph
Okay, what
cyst.
okay. So which are the swellings which can go rapidly here?
any malignancy, parotid abscess.
Right. Good. So malignancy, how rapid it can go?
Within months, days.
So there is a difference between rapidity pertaining to an abscess and pertaining to a malignancy. They both are not in the same rapid fashion, right?
Yes, ma'am.
Okay. You said there is no history of increase in the size of the swelling. So where does it increase? On the inner aspect or on the outer aspect? Where does it increase?
Outer aspect, where the swelling is there due to
In what condition you will expect this to have an
any
increase in the size?
salivary colic, like any stone in the salivary duct, causing stasis of secretions, leading
So you said
to increase.
but you said this patient doesn't have any pain over the swelling. Then why you want to ask about that history?
Is it
The
common
patient has,
in
if a
this
patient
swelling?
has got a pain in the swelling, then you can ask about that history,
Okay, ma'am.
right? The
Okay,
patient
ma'am.
doesn't have any pain, right?
No,
So
ma'am.
If there
So
is
what-
no pain, what made the patient to come to the hospital after 8 years?
I'm sorry, madam.
No, you told the swelling is present there for past 8 years.
Yes, ma'am.
What made the patient to attend the hospital now?
What made the patient to come to you after 8 years when there is no pain?
He came after so his relatives are telling something, it may happen, go wrong, so he came, ma'am.
Okay.
Okay, you have also asked about history of fever. Why history of fever?
Yes, ma'am. Any inflammatory swellings will have
Of
fever
8 years,
abscess.
8 years duration.
No, ma'am.
So again, that also can be pushed aside, right?
Excluded. Okay, ma'am.
Right. How does an inflammatory fever can produce a parotid swelling? What will be the type of parotid swelling? Will it be unilateral?
Ma'am, sorry, ma'am. Fever, ma'am. It can be bilateral also, ma'am. Like mumps,
Okay.
sialadenitis, HIV associated sialadenitis,
Right.
and
So
autoimmune
say-
disorders, Sjogren's syndrome, sarcoidosis.
Mhm. So those things will be presenting with fever, Sjogren's syndrome.
No, ma'am.
See,
Mumps,
those will be
viral infections, bacterial infections will present with fever.
right. You asked about history of difficulty in mouth opening. Why?
Any trismus, ma'am. Any involvement of the medial pterygoid muscles.
So involvement of medial pterygoid, when you anticipate malignant swelling, you would ask about those things, right? In this benign condition, when the swelling is occupying only the just behind and below, right? Such a small swelling, why it should produce a difficulty in opening the mouth? Why you
It will
wanted to
not
rule out
produce.
trismus? Again, it will not produce, right?
Yes,
Trismus.
ma'am.
I think, right? The causes of trismus already discussed in the previous case itself, right?
Yes, ma'am. Yes, ma'am.
Right. And again, you have asked about history of trauma. Is it a matter of completion's sake or why?
For completion only.
Say, never ever present for completion's sake. So try to find out if at all there's going to be any reason for any swelling, right?
Okay,
Right.
ma'am.
Next slide. Coming on to history suggestive of facial involvement. Tell me what are the histories you like to ask? You asked about the
Sorry.
difficulty.
Yes, ma'am. Frowning of the eyebrows, lifting the closure of eyelids, and any deviation of angle of mouth, drooling of saliva, blowing of cheeks, whistling.
So
When
if
there
you
is
have
difficulty in opening and closing the mouth.
Okay.
Facial nerve, does it cause any involvement? Does it cause a difficulty in opening the mouth and closing the mouth?
Just
the foot.
Deviation for that only.
Deviation doesn't cause us difficulty in opening and closing, no? Sometimes the
Okay.
patient may not know there is a deviation of the mouth unless any person notices and tells him.
Yeah, usually facial nerve involvement, the other person will say, உங்க வாய் கோணிக்கிச்சு பாருங்க அப்படின்னு usually the neighbors will tell.
Okay.
Right. Whenever there's going to be a loss of symmetry in the face, when you try to, it will be noted by the neighbors. They will try to tell you. Okay.
Okay.
Right. So you have asked about this dry eye salting to rule out an autoimmune disorders, right? Got it,
Yes,
right?
ma'am.
Fine.
This history of loss of weight and loss of appetite is also not needed for
Okay,
a
ma'am.
study presenting for 8 months.
8 years.
Any history of sudden increase in
years.
size or anything, you can ask for any history of loss of weight or loss of appetite.
Okay, ma'am.
We'll go with the next slide.
Will you ask for any recent illness or major surgery?
Yes, ma'am. To rule out ciliaridinitis.
It has been there for past 8 years, no?
Yes, madam.
If it had been for an acute onset, then you can think in a person who would have a recent onset, patient would have been intubated, the oral cavity hygiene would not have been maintained. Those cases, the patient can develop a bilateral parotitis, right?
Okay.
All those things of a shorter duration, not for a longer duration. See, sometimes you people have a proforma. With that, you tend to present it, right?
They
For
are
all
not customizing it. They are telling everything as in the template.
Yeah. Yes, ma'am.
And why no history of mumps in the past?
Mumps parotitis can cause. It can also cause carcinoma. Risk factor. Risk factor. Viral
Risk
infection.
factor for malignancy? I don't know.
Viral infections can cause.
No. Sure, mumps will cause arthritis, something like that. But what about in CA parotid? I don't know. I don't think so.
Which book tells so, ma?
We
shall update it if it is there.
Just viral infections.
Okay. Right, we'll go on with the examination. Come on. Yeah.
Show the patient. This is below and behind the ear, or behind the ear?
Below and behind the ear lobe.
But in the picture, it doesn't look like below and behind. Okay, you proceed with your examination finding. Okay. We'll know.
Coming to general examination, patient is moderately built, moderately nourished.
To the local examination.
Okay. Coming to local examination and inspection, swelling of size approximately 2 cross 1.5 centimeter present below and behind the lobule of the right ear, obliterating the retromandibular groove, which is oval in shape. Surface over the swelling appears smooth. Skin over the swelling appears to be normal. Extent of the swelling, superior extent is up to the level of measured process. Medial extent is just behind the ramus of the mandible. Lateral extent up to the level of the sternocleidomastoid muscle. Inferior extent just above the angle of mandible. Edges of the swelling are well defined. There is no swelling in the opposite side of the face or no other swellings in the neck. On palpation, there is no warmth and tenderness over the swelling. Swelling of approximately 2 cross 1.5 centimeter palpated below and behind the right ear lobule. Surface of the swelling is smooth. Extent as mentioned in the inspection. Swelling is firm in consistency. Skin over the swelling is pinchable. Swelling is mobile. Swelling becomes prominent on clenching the teeth and becomes less prominent on opening the mouth. Mobility is not restricted on contracting the masseter muscle. Parotid duct is palpable normally. There is no bony tenderness. Coming to oral cavity examination, mouth opening is adequate. Fair oral hygiene. There is no fullness in lateral pharyngeal wall. Tonsil is not medially. There is no pus or blood discharge from the orifice of the parotid duct. Bimanual palpation, deep lobe is not palpable. Bidigital palpation of the parotid duct is normal. Coming to examination of the facial nerve, there is no loss of wrinkles over the forehead. Nasolabial fold is maintained symmetrical on both sides. Eyelid closure is normal on both sides. There is no deviation of angle of mouth. Puffing of cheek is normal. Examination of the lymph nodes, there is no palpable lymph nodes, and jaw movements are normal.
Wait, go to the first slide on inspection. Next one. The swelling, no?
Yes, ma'am.
You are telling edges well defined.
Borders of the margins of the swelling are well defined. Margins are well defined.
And you are saying on the inspection of this one, and suddenly you are going back to the swelling in the opposite side or no other swelling. When you are doing
On
on this
inspection,
side swelling, only you finish it off inspection, palpation, and then go on to the next side, opposite side.
okay, ma'am.
Inspection, that's all.
Yes, ma'am.
You told skin over the swelling is normal.
Yes, ma'am.
Okay. Go on to the palpation. Surface is smooth. Next. But you are on the picture. It seems to be the skin seems to be a little bit shiny, no? Please put the picture. The skin seems to be a little bit shiny, no?
But I do not make out.
You couldn't make out. Okay, go to the palpation. You told on clenching the teeth, the swelling becomes prominent. What is the attachment of the masseter?
I'm sorry, ma'am.
You told on clenching the teeth, the swelling becomes prominent.
Yes, madam.
But here the swelling is well behind the ear. What is your attachment, insertion, or origin of the masseter?
Masseter muscle. I
Is
don't
the
know.
swelling situated on the masseter?
No, ma'am.
Then clenching of the teeth, what does it do? It makes the masseter muscle taut. And you try to see whether the swelling is situated on the masseter or under the masseter. Right?
Yes, madam.
So where is the parotid located? In relation
Between
to
the
the
ramus of
masseter?
the mandible and the sternocleidomastoid, above external auditory canal, below angle of the mandible.
In relation with masseter, where is the parotid located?
Parotid is located superficial to the masseter, ma'am.
Right. Is there swelling situating on the masseter or it is well away from it?
Away from the masseter, ma'am.
Then why
No,
did you
you are
clench?
telling this.
Clenching the teeth.
Okay.
Mobility non-restricted on contracting the masseter.
Usually when you have an anterior swelling which is coming almost in front of the tragus, then you do these tests, clenching the teeth, asking the patient to open the mouth and see whether there is a reduction in the size of the swelling or it is becoming more prominent. Those are things to be looked for. But your swelling is almost in the post-auricular region.
Okay, ma'am.
The swelling
Right.
is freely mobile.
Yes, ma'am. Mobile.
Are you able to push back the swelling to the anteriorly?
Yes, ma'am. Mobile in all the reactions of both vertical and horizontal.
When you ask for no, palpated for no bony tenderness, which bone tenderness?
Mastoid bone tenderness.
Mastoid. Why?
Any in carcinoma, bony involvement can be there.
Bony involvement. Parotid. What are the
Bony
signs
is
of CA parotid?
rapid increase in size, pain.
Signs.
Some hard in consistency.
Okay.
Facial nerve involvement, metastatic cervical lymph nodes. Trismus.
Anteriorly?
Fixity to the muscle, to skin.
Okay, where did you palpate the duct? Palpable normally.
By clenching the masseter, by rolling the fingers over the contracted masseter, ma'am. Midline of the line joining, imaginary line joining tragus to midpoint of ala of the nose and the angle of mouth. 1 centimeter.
Palpable. Normally, duct is palpable.
Ma'am?
Normally, the duct is palpable.
Any stone impacted means it will become palpable.
No, you told duct is palpable normally. Normally, you will be able to palpate the duct.
On rolling over the masseter, we can palpate for the parotid duct.
Only around on the clenching the teeth, only at the margin of the masseter, you will be able to palpate.
Yes, ma'am.
Next slide.
What is the normal anatomy of the parotid duct? Where it is situated?
It are landmark, sir. So
A
sorry,
landmark,
landmark,
yeah.
sir.
Yes, landmark, yeah.
Landmark, situated 1 finger breadth below the zygomatic bone.
No, there has to be a longitudinal extent. There has to be horizontal.
Yeah, arises from the anterior border of the masseter and pierces the vaccinator muscle and opens into the vestibule of the mouth.
What is the anatomical line? What is the anatomical line where you trace the parotid duct?
Imaginary line from the tragus of the mandible, from the tragus to the line joining ala of the nose to angle of the mouth. Mid third, we have to palpate for the parotid duct, sir.
Okay, right. Now, do you palpate by manual examination?
Yes, sir.
What is bimanual, by the way? When you use both the hands, that is called bimanual. Are you able to put the entire hand into the oral cavity? Look for the deep lobe?
No.
Next to impossible. All your fingers would have been bitten by the person.
To bimanual palpation, yes, written.
So when you are doing deep lobe palpation, where do you put your external finger?
Behind the ramus of the mandible.
Duct is bidigital bar.
What is that area called as?
So retromandibular sulcus.
Retromandibular sulcus, yes. Okay, on inspection, how do you say there is a enlarged deep lobe is there?
Deep lobe.
Fullness in the lateral pharyngeal wall.
On inspection, how do you say there is an enlarged deep lobe?
Fullness in the lateral pharyngeal wall. Fullness in the lateral pharyngeal wall. Tonsil will be pushed medially.
Yes. Okay.
When the tonsil gets pushed medially, what will happen? The uvula will get deflected.
Uvula will get pushed medially.
Yeah. So try to look for that.
On inspection, if the deep lobe is not visible or the uvula is not pushed opposite side, you need not do a deep bimanual palpation one. And if you are doing a bimanual palpation, you have to keep in a mouth gag and put your finger.
Okay, sir.
You just put your finger inside, the patient will bite you. Okay.
Okay, sir.
And for the duct, it is bidigital. Use both the digital.
There is no swelling in front of the ear in your case?
Sir, sorry, sir. I can't hear you, sir.
You said there is no pus or dust discharge from the orifice of the duct. Where is the duct located? Duct orifice?
Opening is opposite the crown of the upper second molar tooth.
Is it normally visible for everyone?
No, ma'am. If there is any impacted stone or something like that, it will be visible.
Then you said there is no pus or discharge from the orifice of the duct.
From that area, around that area, there is no discharge.
Okay. So usually not that easily visible, right? So either you can give some Silogox and ask the patient to swallow and then try to see if at all there is a discharge from that side, right? Otherwise, it's not that easy for you to appreciate the discharge from the orifice. If at all that duct area is going to be inflamed, then you'll be having some redness or the changes will be seen around the duct orifice. In that case, you'll be able to localize.
Yes, you should be able to tell that very redness or any
okay, ma'am.
swelling near or on the site of the orifice of the duct.
Okay, ma'am.
You go to the deviation of the angle of the mouth. Which side the angle of the mouth will be deviated? The
opposite side
or the normal side?
Normal side.
The normal side. Okay. What group of lymph nodes you palpated?
Submandibular, submental, and upper jugular, lower mid jugular.
What about parotid?
Parotid, there is no palpable parotid lymph nodes, ma'am.
Okay.
How will you differentiate between a palpable parotid lymph node and a parotid gland?
It will be superficial to the lymph nodes will be superficial to the parotid fascia, ma'am. So on stretching the deep fascia by opening the mouth, lymph nodes will be more prominent, whereas parotid swelling will become less prominent.
Good.
Okay, proceed with your diagnosis.
Diagnosis. My provisional diagnosis: a benign tumor arising from right parotid, probably a mixed parotid tumor.
Why did you choose the diagnosis as a mixed parotid tumor?
Pleomorphic adenoma is a pathological diagnosis, so that also pleomorphic adenoma is the most common benign tumor in parotid gland.
Okay.
And it's slow growing nature.
Fine. So
what is mixed parotid tumor? Why it is called mixed parotid tumor?
It has both epithelial and myepithelial mesodermal elements.
Okay. Okay, what investigation will you do?
Ultrasound of the neck, and ultrasound guided FNAC, CT neck. If there is a suspected
ultrasound of the neck and ultrasound guided
parotid FNAC.
FNAC from where?
From more representative area of the swelling.
Right? What is representative? Which part of the swelling will you take an FNAC?
More solid areas.
Solid areas. So you are telling both solid and cystic areas are there in the swelling?
If there is solid and cystic areas, means we have to take from.
You told this most probably it is a pleomorphic adenoma. Will a pleomorphic adenoma has both solid and cystic areas?
No.
It's such a big swelling, 2 into 1 centimeter. You can take a FNAC directly, no?
Yes,
if you are suspicious of any malignancy and any sudden increase in the size, then you look for the signs of malignancy. You can check from the ultrasound guided.
Okay.
So what management? Why you want to do a superficial parotidectomy?
It's gold standard treatment
Why?
for pleomorphic
Why?
adenoma.
Why?
Because if we do enucleation, even though pleomorphic adenoma is encapsulated, it has got capsular deficiencies through which it forms pseudopods. If you do only enucleation, means there will be recurrence. There will be chances of recurrence.
So what is superficial parotidectomy?
Removal of the parotid superficial lobe above the faciovenous Patti's faciovenous plane, above the facial nerve.
How will you identify facial nerve?
Conley's pointer or tragal pointer, which is the junction of the bony and the cartilaginous ear canal. 1 centimeter deep and inferior to it, we can find the trunk, ma'am. And next one is above the posterior belly of digastric, we can trace the trunk. And lateral to the styloid process also, we can trace the facial trunk.
Then?
Retrograde method.
Then?
Tympanomastoid suture below the tympanomastoids.
You are in a sophisticated center. You have all equipments.
And no monitoring.
No monitoring or no stimulator?
Stimulator.
No stimulator. So how many branches the facial nerve has?
It divides into temporofacial and cervicofacial. Further divides into temporal, zygomatic, buccal, marginal mandibular, and cervical.
Okay. What is the chances of getting a parotid fistula after superficial parotidectomy?
Less than 5%.
Why?
Huh?
Why? Do you identify the duct and you'll ligate it, or you'll just do a superficial parotidectomy?
We can identify it and ligate it.
Identify and ligate.
Then
From
what will
which
the
part
deep
of the
lobe do?
salivary gland it?
When you do
Yes, ma'am.
I'm
Madam?
sorry.
what will happen to the
Madam
deep lobe? You ligate it.
Ma'am, deep lobe will also will not like it, ma'am.
You like it when the deep lobe want it to enlarge? It going for any silolithiasis or something will not form?
Yes, ma'am, will not like it.
Will not like it now. Okay. Fine. See, you said you're suspecting a mixed parotid tumor, right? But you're doing an FNAC, it comes as a adenoid cystic carcinoma.
Okay.
Now what do you want?
Total conservative parotidectomy, ma'am.
Want you to do some evaluation before that,
Yes.
some staging or something else?
Yes, ma'am.
What should be done?
CT neck or MRI?
Or
CT
MRI?
neck or MRI? Which one?
Which one? Which one you
MRI,
want?
ma'am. MRI, ma'am.
Why you want to do an MRI?
Because adenoid cystic carcinoma is more predilection for perineural invasion. So
Very good.
I will do MRI.
How does a perineural invasion look like on a CT or an MRI? How does it look like?
Loss of fat play, hyper enhancement.
Standing.
Fat.
The nerve might be enlarged. Okay.
Okay.
So when you compare it to the opposite side, the nerve might be looking bigger, right? As it emerges out of the stylomastite foramen, it will try to widen it and it comes out, right? And you'll be having an entire pore of length of the nerve would be thickened, right? So those things can be looked into when you take an MRI,
Okay.
right? You want a CT neck also for a mixed parotid tumor. Is it mandatory or an
No,
ultrasound is sufficient? Huh?
ultrasound is sufficient.
Then why you wanted to add a CT neck here?
Just for completion check.
Again, just for completion sake, right? Okay. Which is the commonest nerve which is likely to
See, if
get
it is
injured?
malignancy, and if you think there is a involvement of the supratentorial compartment, skull base involvement, you can do a CT parotid protocol, which
Okay, sir.
involves which extends from the base of the skull to the clavicle. That is CT parotid protocol. So you
Okay,
can
sir.
know where there is widening of the foramen ovale. That indicates it involves the skull base.
Skull base.
If it is a malignancy.
Something like a pancreatic protocol. This is a
But here
parotid
your
protocol.
all features are in favor of benign one.
Benign tumor.
And parotid protocol. CT neck is not. Once an ultrasound is very, very, very informative as far as notes are concerned.
Okay,
and
sir.
when it comes as adenoid cystic carcinoma, when you say the predilection for nerve involvement, you can go in for a MRI.
MRI. Okay, sir.
Otherwise, MRI is not indicated.
Okay.
So ultrasound guided FNAC will suffice for a pleomorphic adenoid.
Okay, sir.
Okay, if you have a nerve which is
not
injured,
an array of investigation which are all available is needed for is not enough. Routine anesthetic work to manage superficial parotid is enough.
Which nerve you are worried about when you are going to get injured?
I'm sorry, ma'am.
Which is the nerve you are going to get worried about when it gets injured?
Zygomatic branch. Zygomatic branch.
Why?
Because it supplies orbicularis oculi, ma'am. So patient will be getting exposure keratitis, which can cause corneal ulceration and blindness, which can lead to blindness.
So when you suspect injury to that branch, what will you trying to do?
If small segment is lost, ma'am, we can primarily repair by 80 proline, something like that, ma'am. If a segment is lost, means we can do
What
cable
do you mean by
graft.
something like that?
No, ideally, when you do
Be specific. You don't tell this or that or something like that.
You do
80 material proline nylon.
I don't have an 80 proline in my place. In that case, what I am supposed to do? And I'm not sure whether I have injured it or there's a considerable segment which has been lost. What can be done?
Cable graft, ma'am, with the greater auricular nerve.
Okay. Any other? I don't have the, what to say? I don't know the technique how to do it. In that case, what can be done? If you're practicing in a rural area, when you don't want to avoid, you want to avoid something.
I can't get to you, ma'am.
See, I know that I have injured the zygomatic branch, but I'm not able to do the repair.
Okay, ma'am.
Right. So what prophylactic thing I can do so that this patient will not go in for a complication in the eye?
Post-operatively, ma'am.
Intraoperative தான் பண்ணிட்டு இருக்கோம் நம்ம procedure. We are
Yes,
doing
ma'am.
the procedure now. So now what I am supposed
Prevent
to
the
do?
injury, what will you do?
Like no monitoring we can use, ma'am.
Hey, already the injury has happened.
Okay, ma'am.
You are in a rural setup. You are the single person. You don't have any assistant to do all those cable graft and other things. In that case, what can be done in order to avoid this eye injury, corneal injury?
Lateral tarsography.
Appada. Very good. Right.
To prevent all this one, what you can do is while draping, it is almost similar to thyroid draping. But when
Yeah.
you drape it, see that the outer canthus of the eye is exposed.
Visible.
Yes.
So that when you are operating, you will know if there is any twitching or is there
Okay, sir.
injury to the, you can identify. So you can prevent the injury to the nerve.
Okay, sir.
Okay. Well, draping itself, that's why the outer canthus should be
Visible.
exposed. Okay. As you
Okay,
said,
sir.
lateral tarsosaphy. The nerve is involved. If it is distant, you can do a primary suturing if you know. If
Okay, sir.
if the gap is widened, so where you cannot do a primary suturing, you can put a cable graft.
Yes. Okay, sir.
Okay. What are the incisions available? Parotidectomy.
Sir.
Incision available for a parotidectomy.
Lazius incision or modified Blair incision.
I don't know what is it.
It consists of 3 components: preauricular, mastoid, and cervical components, sir.
Yeah, you go up to the mastoid or below the mastoid.
Up to the just below the up to the mastoid, sir.
When you come to the cervical region, where do you draw the incision?
2 centimeter below the angle of mandible.
Why?
To avoid injury to marginal mandibular nerve.
How do you identify the marginal mandibular nerve when you're going to do a procedure, especially on the submandibular gland?
It forms a loop like
Okay.
and turns upwards.
So you go about 2 finger breadths below the mandible and make an incision so that when you raise the fascia, the nerve also goes along with it, right?
Okay.
Or else you try to identify the facial vein and try to ligate it. When you try to pull the facial vein up, what will happen? You can preserve the mandibular nerve so that it doesn't get injured when you're going to do a surgery there.
Okay.
Right? If you have, okay, post-operatively, your patient has got a leak now, right? There is some serious, post-operatively, your patient presents with some serious discharge and the patient eats. Okay, as he eats, he finds some serious discharge which is coming out. How will you manage?
From the external surface.
Yeah, external surface.
I will diagnose as parotid fistula.
Okay.
And
why can't
we
it
can
be an
give,
infection?
ma'am?
Why can't it be a simple infection?
Yes, ma'am. Wound infection also it can be.
So first always rule out basic things, then always come for a parotid fistula, right? If it's a parotid fistula, right, then
I can manage conservatively by anticholinergics, ma'am, by using glycopyrrolate to decrease the secretions.
Then
I can explore and
what are the types of fistulas?
intraglandular, the glandular fistula and from the ductal fistula, ma'am.
Very good. So which fistula is easy to repair?
The glandular.
Glandular is difficult, okay, because you don't know where it is coming from. When you have a ductal fistula, you can try to do a mass utilization on the intraoral aspect and you try to drain it inside, right? Whereas when you have a glandular fistula, what has to be done? You need to remove the deep lobe.
Yes,
okay, when it's causing a persistent ailment that the patient is presenting with, you need to remove the deep lobe. Any other method can be done for tackling this fistula?
We can pass 2 probes from the external site and one from
That
the
is for the duct fistula, glandular. People have tried radiotherapy,
radiotherapy. Okay.
okay, for these fistulas. What is the name of the procedure which is being done for the ductal fistulas? Any surgical name?
Seaman and true.
It's Newman or
Newman
Seaman.
and
Newman Seabrook's procedure.
Newman Seabrook's procedure.
Okay. Right. Okay, your patient is presenting with a parotid abscess. How will you manage?
I will give antibiotics and incision drainage, ma'am.
How do you make the incision?
First skin incision vertically in front of the tragus. And to open the fascia, I have to put horizontal incision.
Okay.
Why vertical incision? Why not transverse in the skin itself?
Superficial temporal artery.
No, that is a deeper one. It is along the Langerhans lines.
Okay.
That area, Langerhans lines, is along the vertical part in order to avoid the scar.
Okay.
And in order to avoid the duct, you will do the
Horizontal.
the fascia along the line of the duct transversely.
What is the appearance when you have called as when you have an edema in the face and the area of the parotid region? What is it called as?
Brawny edematous subinduration.
Brawny induration. Very good. Okay, good.
He's nicely presented and he has
almost answered everything. Finally, we can ask for the course of facial nerve to sum up.
Course of facial nerve.
Yeah, I think you would have been prepared. Yeah, just tell it us.
It arises from the lower pons and passes through the facial canal, internal acoustic meatus, and comes out through the stylomastoid foramen.
It winds around the facial nucleus and makes a colliculus, right?
Yes,
abducent nucleus, right? Not facial nucleus. Abducent nucleus and makes the facial colliculus, and then it enters into the
internal acoustic facial nerve canal.
Okay.
What is that canal called?
Internal acoustic meatus, internal auditory meatus, acoustic meatus.
Basically, fallopian canal.
Fallopian canal.
It's the longest
canal in the
neural canal in the body.
Okay, sir.
What are the branches which is given in this canal?
In the canal, greater petrosal nerve. Nerve to stapedius.
Good.
Carda tympani.
Very good. Right, where does it exit out?
Through the stylomastoid foramen.
Right. Okay, tell me what are the other types of parotid neoplasms you know of?
Benign neoplasms like pleomorphic adenoma, Warthin's tumor, oncocytoma, basal cell adenoma, malignant mucoepidermal carcinoma, adenoid cystic carcinoma, acinic cell carcinoma, adenocarcinoma, salivary duct carcinoma, squamous cell carcinoma.
There's a classification, no?
Who classification?
Only one.
When you have a pleomorphic adenoma, you have a monomorphic adenoma.
Yes, sir. Monomorphic adenoma.
What are they?
Warthin's tumor, oncocytoma, and basal cell adenoma.
Basophil adenoma.
Basophil adenoma. Then you have the carcinoma.
Yes, sir.
Right.
Carcinoma is which is the most common carcinoma?
Mucoepidermal carcinoma.
How many grades are there?
Yes, sir. Low grade, intermediate grade, and high grade.
You have poorly differentiated and well differentiated.
They are well differentiated.
carcinoma.
Sir?
You have a well differentiated and poorly differentiated and a moderately differentiated carcinoma.
Okay, sir.
Okay. Is there
Okay, sir.
anything called carcinoma ex pleomorphic adenoma?
Carcinoma arising from a long-standing pleomorphic adenoma. 15 years duration. 10 to 15 years.
Or in a recurrent pleomorphic adenoma, carcinoma. Which is more
Okay.
dangerous? Which is more dangerous?
Recurrent, arising from a recurrent pleomorphic adenoma.
Carcinoma occurring on the ex pleomorphic adenoma.
Sorry, sir.
Carcinoma ex pleomorphic adenoma.
Yes, sir.
Is more vulnerable.
I think we can close up, sir.
Can we send him? Professor Ajay Khanna, sir, is he there?
Yeah, the other malignancies which are left out are parotid lymphoma, which you should be aware of, and metastasis to the parotid gland. Okay, these also to be added in your list.
Okay.
Because you have an intraparotid lymph node.
Okay, sir.
Okay. Parotid, the developmental difference is there. The parotid is the first one to develop and last to complete. The parotid is the first one to develop and the last one to complete.
Okay,
okay.
Sir.
The other one are arising will develop and finish faster.
Okay, sir.
Okay.
Okay, sir.
So you have an intraparotid lymph node. So as madam said, you may get metastatic to that intraparotid lymph node.
Okay, sir.
Okay, when you have a parotid malignancy,
So this is the one which is ectodermal in origin.
Yes, sir.
Endodermal.
Ma'am?
If you have a carcinoma in the parotid, how will you manage?
First, I will evaluate by doing FNAC and.
So madam has given you the answer. It is carcinoma.
Total conservative parotidectomy.
Total conservative parotidectomy.
If facial nerve is not involved, we will do total conservative parotidectomy.
Okay. So when the facial nerve is involved?
Radical parotidectomy.
Okay. What are the structures which are removed in a radical parotidectomy?
Facial nerve, skin, muscle. If there is bone involvement, bone also will be removed. Facial.
Okay. What are the groups of lymph nodes we are going to remove here? Going to proceed with any neck dissection or anything here?
Yes, modified radical neck dissection.
That also has to be included in your saying the treatment, right?
I'm sorry, ma'am.
Am I audible?
Yes, ma'am.
You need to talk about the lymph nodal involvement also, whether you're going to remove it or not. That also has to be mentioned when you're talking about a buccal cancer, right?
Okay.
What is the role of radiotherapy after surgery?
For T3, T4 tumors, we can give, ma'am.
Okay.
High-grade tumors.
Okay.
Any recurrent tumors.
Very good.
Positive margins.
Wonderful.
Metastatic, if there is any metastatic cervical nodes.
One more.
Metastatic cervical.
When you have a neural involvement.
Perineural
involvement. Okay. What is Frey's syndrome?
Frey's syndrome, custody sweating, ma'am. It is due to inappropriate degeneration of the parasympathetic secretomotor fibers to the skin and sweat glands over the parotid gland instead of supplying it to the parotid, ma'am.
Okay.
So there will be erythema and sweating on smell or a taste of food, ma'am.
Very good. So what is the test you do to determine or confirm this?
Iodine starch testing.
Starch iodine, right? Good.
Starch iodine.
Right. Okay, right. So what is the treatment you want to offer for this patient?
We can give antiperspirants like aluminum chloride and injection botulinum toxin.
Is it available so freely?
Yes.
The cost is quite high for a botulinum toxin to be injected, right? So, ideally, what could be done?
If not controlled means we can do tympanic neurectomy.
Very good, right? Or else you can place some interposition flaps.
Prevention flaps.
Right, that can be done. Right? Okay. You were talking about some extracapsular dissection, no? What do you mean by that?
Removing the gland outside the capsule with some amount of normal tissue.
Some amount, okay. Surrounding normal tissue along with the gland has to be removed. So what is the advantage here?
Facial nerve will not be damaged. We will not expose the facial nerve.
Okay. Apart from that, Frey syndrome also can be
Impair the facial nerve.
avoided, right?
Okay.
Right. Kanagvel sir.
Madam, with the permission, can we wind up?
Yes, sir.
Professor Ajay Khanna sir is there. He will give closing comments.
Okay, sir.
I think sir is Kanagvel sir.
நம்ம ரெண்டு பேருமே உட்கார்ந்துட்டு இருக்கோம்.
இல்ல Kanagvel sir.
That sir was there initially, I think.
Yes, madam. Yes, madam. No problem, madam. We can close. I will inform you.
Okay, sir. Okay, sir.
Thank you, madam. Thank you. Thank you.
Thank you so much, sir.
Well, Mohammed, you want to ask any questions to the ask? You can.
No, sir.
Yes. Thank you, Anandi madam. Thank you, Babita madam.
Thank you, sir.
I think
Thank
he
you.
did a good job. He read well. Mohammed, you did a
Thank
good
you.
job of reading
Thank you.
and presenting very well. Yeah.
Thank
You
you.
the same, right?
Okay.
I think
Well
it
done.
goes to HOD and your professor.
Thank you, madam.
Yeah. Thank you, sir.
Thank you. Well done, Mohammed.
Thank you,
Thank
sir.
you.
Thanks.
Thank you.
Sir was there. Shall we leave then?
Yes, madam. You can leave. I'll inform
Yes, sir.
Kanagvel.
Thank you.
Once we leave the meeting, I think he was driving.
Okay.
Thank you, sir. I leave it.